Good afternoon, class. Happy April Fool's Day. Before we get into the slides for this week, I did want to talk about some things that popped up in the news that are current events that resonated with me and had to do with some of the class discussions we've been having. So the first one is the New York State budget. I'm not sure if you know, but every April, the governor has to pass a budget, and the budget has to be final by April 1st, and the budget has to be balanced. And a lot of times, one of the biggest items of the budget is the healthcare uh, outlays, how much money the state's going to spend on healthcare. Between education and healthcare, those are one of the biggest parts of the budget. $175 billion budget for New York State has to be balanced every year, and it's something that always comes down to the wire. And so today, April 1st at 11 a.m., you'll see this Crain's article that popped up discussing healthcare impacts that are done by the budget. So just wanted to speak to some of them. So again, $175 billion spending plan. It includes a 550 million, increase in Medicaid funding for hospitals and nurses. And the reason why I bring this up is because we talked about in last class uncompensated care. And one of the vehicles to pay for uncompensated care is something called Medicaid Disproportionate Share Hospital Program. And what that does is say hospitals that have low income patients and hospitals that see a lot of uncompensated care, there's a pool of money that's set aside for them to receive money to offset all of their uncompensated care and offset all of their low income patients. And part of the cuts that were going to happen was the state was saying, we don't have to spend as much money on hospital benefits through Medicaid, Medicare, and other state programs because DSH will pay for it. However, the DSH money wasn't coming through, and so Governor Cuomo had to put the money back in, and that money accounted for $550 million increase in Medicaid fundings to offset what they're not going to get from Medicaid Disproportionate Share Hospital Program cuts that really affect safety net hospitals. And safety net hospitals are usually community-based hospitals and ones that have a very high proportion of Medicaid and Medicare. And so how does this tie back to our class? Well, we spoke about how there's cost shifting. And so a lot of these hospitals are saying, if I have a lot of Medicaid members and a lot of uncompensated care, I have to offset those losses by getting revenue someplace else. And so what they try to do is shift it to commercial and private insurers. And if they can't shift it over, then what they do is they rely on the state through these DSH payments so that they can offset those losses. So I saw that article and it made me think about our class. At the bottom of this article, you'll see the last paragraph. Another thing that the government did was reaffirm and codify the Affordable Care Act. So as you know, in the news, you probably saw at the federal level, the Affordable Care Act went to the federal government and went to the Supreme Court. There's we'll end up at the Supreme Court, but there's a appellate court that ruled on the Affordable Care Act and ruled that if one piece of the Affordable Care Act is unconstitutional, then the whole thing is unconstitutional. And the Trump administration backed up that court. And so you'll see all of the for-profit insurers' stock prices took a dive because now they're worried about the Affordable Care Act going away. And the other thing that happened was the New York State took the act to codify provisions of the Affordable Care Act, basically to say, no matter what the federal government does, if the federal law changes, New York State law stays the same. So they basically put in Affordable Care Act rules into the state law through this budget process. And so that's reaffirming the Affordable Care Act in New York, regardless of what happens. Now, why do you think the state government did that? We talked about uncertainty. Arrow speaks about uncertainty and how uncertainty makes markets inefficient. Well, this brings certainty back to the markets. So all the health insurance plans in the market are now feeling a little bit more stabilized, knowing that New York State has law that would keep the Affordable Care Act in place, even if the federal level repeals it. And so again, two topics that we talked about in markets, government intervention to bring certainty. And when you have certainty, then supply and demand pretty much stays status quo. The last piece is in here, which is very interesting, if you keep reading through this article, this Crane's article, and I'll post it to the Canvas site, is there's actually going to be a health-related budget provision that's creation of a State Department of Health study. And this State Department of Health study is going to determine how staffing enhancements and other initiatives could be used to improve patient safety and the quality of healthcare service deliveries in hospitals and nursing homes. So in our 2 weeks ago in the physician class, we talked about staffing ratios, and we talked about economic studies that looked at quality and how quality was impacted by staffing ratios for nurses, and we talked about shifts. And so it's just very interesting to see economic principles in everyday life here. And obviously, the New York State Nursing Association urged the state legislature to mandate the ratio of registered nurses to patients. Why do you think that is? They want to mandate a ratio to keep the supply side high. The study would look at how staffing levels for registered nurses, licensed practice nurses, and certified nurses' aides affect patient care. So it's very interesting to see a lot of the economic principles that we've been discussing in class are on the front pages of headlines for healthcare in New York. So hopefully you guys can read those articles and you find them interesting. Now, let me just touch on the case study. So I've been reading through your case studies. I think you guys explain the gist of the case study very well. The gist of it was, if you're trying to find out why healthcare went up, the reasons healthcare went up from 1940s to 1990s are different than why they went up from 1990 to 2009. 1940 to 1990, it was all demand side. We gave people insurance. Once they had insurance, they used it, right? So it's all demand side. But from 1990 to 2009, it was all supply side. The supply side found more reasons to diagnose patients because they lowered standards, which increased patients. How did they get away with that, right? The only way they got away with that is because of physician agency, asymmetric information. That's key. And so the leading cause of increases in healthcare from 1987 and beyond was because we found more people that were sick, and then the cost of the sickness went up. So you found more people, right? You created demand, physician-induced demand, and then the price for each person that was sick went up. Higher treated disease prevalence and higher spending per treated case. 50.8% and 39% respectively for those two reasons, the reasons why costs went up. The other thing is it went up higher. Increased treated prevalence went up higher in Medicare. Why? I was hoping that people would talk about why in the paper. The main reason is Medicare is for elderly patients and for disabled patients. So your sickest patients are in that block. So of course the cost would go up, as opposed to private insurers. They're mainly under 65 and they're healthier. They're between 18 and 65. So it's much healthier, which is why it only went up by 33%. But even with the healthier population, the prevalence still went up 33%, which just shows you how much. Now, there's an argument. The reason why we increased the prevalence was because we were treating more for prevention. That's one theory. But if that theory is true, then the cost should have went down from 1987 to 2009, and we saw it gone up, which talks about the medical arms race, right? They mentioned lab, x-rays, radiology. The cost went up, but it did not do anything to outcomes. Whenever you see costs go up with no change in outcomes, it's waste, inefficiency in the system, which speaks to the medical arms hypothesis. And then HHI, different hospitals were able to charge different prices based on where they were. Hospitals in rural areas were able to charge more money than hospitals in very dense area. Now it also depends on if they were a differentiated product oligopoly, meaning did that hospital specialize in a certain treatment? If they were the only ones that specialized in that treatment in a certain attachment point, they could charge more money. And then monopoly rents, last but not least, they were able to charge more money because they were physicians and they had the ROI and they also had the return on investment and they were able to build more money. The monopoly rents are when physicians can charge more money or receive wages that are higher than the average because there's so few of them, all right? And they have the leverage. So those were the economic concepts I was hoping to see in the case study. So it's great to do a summary of the case study, but then relate it back to some of the discussions we had in class, okay? Now, on to the case study data. So the case study data was from the National Medical Expenditure Survey. So this website allows you to get access to the National Medical Expenditure Survey. So if anyone is interested in getting more information and wants to see the data by year, feel free to go to this link. When you get to this link, click the Use, Expenditures, and Population tab. You can go into the other ones, but this is the main one that's going to show you costs. And once you go in, you can move things around and look at the data in different ways. And this can help you for your final paper if you want to show different costs by hospital, by physician, by home health, et cetera, et cetera, et cetera. But once you get into it, I'll just show you an example. See, you can pull different statistics. And so what I just pulled quickly is two different charts. The first chart shows total expenditures in millions. So this is how much money we spend on healthcare from 1996 to 2006. So you can see it goes from 600,000 all the way up to a little bit above 1.6 million, right? And I think this is in billions. So you can see the trajectory, and it goes up. It goes up very high, a big spike. And on the flip side, I also chose give me the mean expenditure per event. So on average, how much was each healthcare event from 1996 to 2006? And you can see the average cost went from 150 up to maybe a little under 300, call it 275, maybe 280, right? So you can see the lines go up. So as the average cost per event went up, then obviously total expenditures went up. And that's exactly what the book, the case study was talking about. They were saying from 1987 to 2009, we saw more people getting sick, and of the people getting sick, it cost more money to treat each person. So I leave that link to you for your own devices. Feel free to go through it and analyze the data. It pulls the National Medical Expenditure Survey, which is all across the country, how much money we spend on healthcare. And it's a very important database that we use in health economics to look for trends over time. Okay? All right. Let's jump into the chapter. So an intro question. A man walks into the office of a life insurance company. He wants to buy a $1 million life insurance policy for a term of 1 day. Your company will have to pay $1 million to their heirs if and only if he dies tomorrow. You know nothing about the man. How much do you charge, right? So think about this. Someone comes into your office. They say, I need $1 million life insurance policy, but I only want it to last for April 2nd. After April 2nd, it can terminate. And then on April 3rd, it's all good. And I only can charge them for that 1 day. So most likely you would assume that he knows something we don't know, he or she knows something we don't know, and we wouldn't charge anything less than 1 million because the risk is so high that in 1 day they might be doing something so risky that they'll kill themselves, right? That is a they might kill themselves, or they're doing something very risky, like they're going bungee jumping, they're climbing Kilimanjaro, they're swimming with the sharks, et cetera, et cetera, et cetera. Since that's such a risky proposition, an insurance company avoids risk, so we're going to charge that person lots of money for that 1 day, right? That's basically the gist of the story. We won't pay them less than $1 million, even though it's only 1 day, unless we could and we know nothing about this person. If you are a risk-adverse person, you would charge more. You wouldn't take a chance on paying a guy $1 million. Plus, let's think about it. If I know I have $1 million policy, if anything happens to me on April 2nd, tomorrow, how do you think I'll act? Will my behavior be different, right? We talked about moral hazard. Exactly. So I'm going to think I'm, sort of invincible because I know if anything happens, I don't have to worry because my family will get $1 million, et cetera, et cetera. Okay. So on that note, this talks about adverse selection. That's basically what the class is about. I posted this audio to the discussion board. Please go there to read the questions and provide your responses. I just would like you guys to read another person's recommendation and give a response. It's all around Memorial Sloan Kettering. Let me just give you the background of this. Basically, there was a company called Health Republic. They were one of the largest insurance companies on the exchange in the Affordable Care Act in New York, roughly 2015, 2016. They went out of business, and Health Republic was the only health plan that had Memorial Sloan Kettering, right? Then they went out of business, so we had to figure out what to do with those patients at Memorial Sloan Kettering. So this audio on wnyc.org is an interesting story. It's 3 minutes long, but it talks about adverse selection. So please take a listen and then go to the discussion board. Okay. I know I had a lot of commercials this week, but then now we'll jump into the content for this week. Okay. So these are things that insurance companies do to try to impact their selection and try to mitigate their selection. Bulk discounts, they will lower per unit price for a large purchase of a commodity. All this means is if one small business buying my insurance, they have 50 employees, I'm not going to give them as low as a price as if I can cobble together lots of different small businesses. So think of 500 small businesses that have 50 employees. If I get a lot of them, then I give them a bulk discount. The same thing happens for hospitals. If my insurance plan is small and I only give them a few patients a month, they're not going to lower their price per unit price. The only way they would lower their per unit price is if I brought them tons of patients. So that's bulk discount. And that's by saying the only way I'm going to lower my rate and take on more risk is if I'm promised a value. And then there's also bulk markups, higher per unit price for large purchases of a commodity. And so you see this argument back and forth between health and plans, health insurers, and employers trying to buy insurance based on bulk markups versus bulk discounts. Bulk markups would be, oh, your population tends to be older. Oh, here's a good example. If we sign up a business and that business has lots of, and this is unfortunate, but this is how the tables work, lots of young women between the age of 21 and 40. And say it's disproportionate share. So it's 80% of the business has women of that age. Because the actuarial tables would say there's a high probability that those patients will get pregnant, then in the charges, there would be a bulk markup because we have to take the risk of potential pregnancies. So we have to make sure we charge a health insurance policy that covers those costs. In the same vein, if you hire a mining company and that mining company has lots of workers that work in mines, same thing, you do a bulk markup because you have a risk that a lot of those patients may get lung cancer. So you mark up the price and because you're charging a higher per unit price for a large purchase of a commodity. That commodity is insurance for a sicker population. Same thing happens with taxi cabs. Taxi cabs are known to be in taxi cab companies like Uber, if they're buying insurance for their staff, they're known to be sedentary, sit in the same place for a long time, not exercise that much, long hours, right? So they tend to be a more expensive group than a typical group, and that's where the bulk markups would come. So insurance companies use bulk markups to protect themselves from risk customers who want a lot of insurance. This is exactly, and it's in the book, the Rothschild-Stiglitz model predicts, okay? So here lies the main topic about adverse selection. So adverse selection, both frail and robust individuals are pulled together. So the whole notion of insurance is we have to pull people together so that the healthy people can pay for the sick people. The whole gist of the Affordable Care Act was I need everybody in the pool. I need everyone to have insurance. We can't have anyone uninsured. If I get everyone in the insurance pool, then I can pool them together so that the young people who are healthy and the people who utilize less services, they're paying in money, and I can use that money to offset the expenses of the more expensive folks. So you add both frail and robust individuals into the pool together. Premium is an average cost of the people in the pool. So the premium I charge, everyone pays the same price, right? The Affordable Care Act requires that you can't charge more than 3 to 1 ratio between your sickest person and your healthiest person, between your youngest person and your oldest person. The Affordable Care Act demands that you can't go more than 3 to 1. Before the Affordable Care Act, there used to be 10 to 1, right? And there's some vehicles where you can even do more than 10 to 1, 11 to 1. But Affordable Care Act, 3 to 1. Frail types are indirectly subsidized by robust. So we talk about cost shifting on the hospital side. This is cost shifting on the insurance side. Robust types exit the pool, leaving only the unhealthy individuals. So think about it this way. Everyone pays an average rate. Sick people are getting subsidized by the healthy people. Healthy people pay the money. And at the end of the year, they say, I paid all that money, but I didn't use it. And then so they leave, and then so the rest that's left over are the sicker people, and so the average price per person has to go up. When that cycle repeats, you readjust the premium, healthy people leave, and you all of a sudden are in an adverse selection death spiral. So this first chart, price is up and down, and the amount of insurance is here on the X. The customers do not buy insurance. These customers buy insurance. So because the price of the insurance is 10,000, people who are like 10,000 is too much money for me. I'm not going to buy it. Then you have a block of people between $0 and 10,000 who decide not to buy insurance. And then only people who buy insurance are people who are willing to pay 10,000 to 20,000. Now, let's talk about why you might not buy insurance. This gets back to marginal utility, right? I will pay 10,000 for insurance to protect me from a loss that has to be at least $10,000 or greater. I will not buy insurance if the loss I'm going to have is less than what I'm going to pay out. For example, if I buy a hoopty, a really crappy car that I bought for $500, am I going to pay an insurance fee? Now, car insurance is mandated in New York State, but am I going to pay an expensive, robust insurance fee on a cheap car that's more money than the car? Probably not. It doesn't make sense. I'm not going to take a risk to throw good money for a chance to try to protect something that's only $500. However, if I buy a brand new Audi, fancy car, and I'm paying way more money monthly and the car costs way more, right, then I'm willing to pay that monthly insurance fee to protect me from the loss of the $50,000, $60,000 car. So that decision is made by the individuals deciding to buy insurance or not. The people who are sicker are saying, I'm willing to pay the 10,000. When the healthy people start to leave, then you get the bottom chart. And the bottom chart is the people who are closest to willing to pay 10,000, they're willing to pay $10,000, $10,100, $10,200. They start to drop off. So who remains left over in the insurance pool are the sicker ones. So I have to charge everybody more money because I don't have enough money coming in. So I raise my price to $15,000, right? I'm going to lose people when I raise the rate to $15,000, and then only certain customers will stick with me because their expenses are more money. And that's when you start to have a death spiral, when you start to have sick people stay in your insurance policy year over year and the health people leave, okay? So how does adverse selection work in health insurance? We looked at it empirically at the RAND study. We're back to RAND. You can't run away from it. Empirical evidence for adverse selection in the health insurance market. The RAND study taught us that adverse selection is real. Individuals are able to predict their healthcare costs for the year to a good degree of accuracy. So what this means? It means if I'm sick, I'm going to get the plan that pays me money up front, so I just pay a copay. Remember the zero coinsurance plans? If I know I'm sick, I'm going to buy the zero coinsurance plan. If I know I'm healthy, I'm going to buy the big deductible plan. That's a problem for insurance because if sick people buy the rich plan, healthy people buy the cheap plan, I don't have a balanced risk pool, and it leads to adverse selection. Specifically, in consumers, they are able to predict their healthcare costs more accurately than health insurance companies. So the only thing I know, because I'm not allowed to do pre-existing conditions anymore, the only thing I know about someone when they sign up for healthcare is their age, their demographics. I might know their race, maybe not. Maybe I don't ask. Maybe I try to back into it from their zip code. Age, demographics, where they work, where they live, right? I have to make decisions based on a couple of data points to predict their healthcare spending. So because I'm making those decisions, I'm going to err on the side of caution. And if I'm going to err on the side of caution, I'm going to bulk up those rates for that population. Families with high predicted costs would more likely want supplemental insurance. So all this means, what we learned from the RAND study is, if I'm healthier, I get the plan that has catastrophic, I'm less likely to give good money to protect me from a loss because I know I won't have a loss. The probability of my loss is low, so I'm less likely to give up money to protect me from a loss. Unlike the sick people, my probability to get sick is high, so I'm more likely to spend more money to protect me from that loss that I think is going to come. So there's several studies that find positive risk coverage correlations in various markets. So as you go through the readings, you will read various studies that are showing empirical evidence for adverse selection. And it's a big issue. And the reason why you've seen health plans pull away from Obamacare, the Affordable Care Act, is because they're trying to avoid adverse selection. So if one plan moves, if that plan is thought of having sick people, then they know that plan, all those members are going to come to their plan. So they're like, I can't stay in this market if that insurance plan is still there. So I have to get out too. And that's why you've seen in the news different plans pulling out. And that's also why potentially Health Republic was leaving the market, because they were the only ones that had the best cancer hospital, Memorial Sloan Kettering, that was a differentiated product oligopoly, right? So they were known for what they do and they're specialized. And so they had a disproportionate share of cancer patients because they're the only ones that had the Memorial Sloan Kettering, which meant that healthy people left, sick people stayed, and their rates went up. And when their rates went up, they had to unwind their insurance policy because they hit adverse selection. So this example just shows typically what could happen in a true health insurance market. Back in the day, in the 90s, when there was managed care, you usually had an HMO plan and a PPO plan. HMO plan, you could only go to network hospitals. You had to go to the hospitals that were in your big, thick book, the hospitals that were contracted with, right? And we use HHI to contract with those hospitals. But then you could also pay up more for a PPO plan, and the PPO plan lets you go out of network. And health plans would pay a fee to out-of-network doctors. And sometimes the doctors would accept the fee. Sometimes they would balance bill and charge a little bit more. So HMO here, for this group, 82% of the enrollment is with the HMO plan. And back in the day, we don't charge anything to the employee for that plan. So they all stay, so 82% of the employees chose the HMO. And out of their paycheck, they paid $0. 18% decided to get the PPO. And they paid $361 a month for that PPO. They decided that their health expenses was more than $361 a month, or there's certainty that they would have health expenses that would be $361. So because of that, they were risk adverse. They decided to buy a more expensive plan to have access to doctors outside of HMO. So 18% decided to choose the $361 plan. 82% decided to choose the smaller HMO plan, right? Then you go from 94 to 95. What happens? PPO stayers, less healthy on average. Look at the PPO people who stayed. 21% were under 40. 21% were under 40, which means the remainder were over 40. 18% were over 60, and they spent 6% more. So those were the people who stayed. Right? You had an older population stay, and they spent more money. The PPO leavers, they left the PPO going into 95. 31% were under 40. 13% over the age of 60, 6% less spending. So they were younger, and they spent less. They said, you know what? This PPO is not all that it's cracked up to be. I'm spending a lot of money, but I'm not using it. So I'm going to leave the PPO and transition to the HMO. So the HMO now has 86% of the enrollment, up from 82, and the PPO only has 14%. Since the sicker population remained, I have to charge that sicker population more money because the healthy people that were subsidizing the cost went away. So the price went from $361 to $731. Crazy, right? Same thing happens into 1996. 15% under the age of 40, very small, 9% more spending into 1996, versus the PPO leavers, 30% were under 40, and they spent 9% less. So by 1996, 91% of my employee population was in the HMO, still $0 premium, and $1,441 was the cost to be in a PPO by 1996. We had to basically double the price in three consecutive years because of how sick the population was that kept it. And then what ended up happening is, which we read in the HIE study, was then we went to high deductible plans and said, I'm going to charge for the HMO and make the high deductible plan $0 premium. That's what would happen in like the 2018s. You have a PPO, you have an HMO, and you have a high deductible plan. And so you can see these insurance markets, the illustration of adverse selections. And this was a Harvard plan, and it's very bad when that PPO population gets smaller and smaller and smaller, right? Because then one person can get sick and totally blow up the pool and make everyone pay more money. Now, there's also evidence against adverse selection. U.S. workers with employer-sponsored insurance in 2001, positive correlation disappears when adjusted for age, race, and gender. So what this means is they say, hey, there's adverse selection. However, if we adjust for age, race, and gender, you start to see it go away. That's an argument from a 2001 study, which is in your reading, right? And so all that means is adverse selection obviously occurs between someone who's 30 and someone who's 60, but adverse selection doesn't occur between the same people who are 60 years old, right? There's also negative correlation. Now, this is interesting. Medicare beneficiaries, interesting study from 2008. The older you get, the more risk adverse you get. And so what this argues is seniors with greater cognitive ability are healthier and more likely to purchase supplemental insurance. What this is saying is seniors overinsure. The older they get, they advantageous selection. They actually buy more insurance than they really need when they're older if they have the money. And so that's an interesting negation against adverse selection argument, saying, no, it doesn't exist in seniors because seniors who still have cognitive ability, they actually are so risk adverse, they actually overinsure, which means you offset, you're actually overpaying for their insurance policy, right? Okay. Then we can relate it to other markets, other insurance type of markets. So think about automobile. Positive risk correlation, you saw in Israel, but not in France. This is in your readings. Life insurance, bulk discounting for life markets for teachers, negative risk coverage correlation. People with life insurance live longer. So this is saying, hey, the people who actually decide to buy life insurance are actually, they're risk adverse, but they actually tend to live longer. And this gets, again, this is a very interesting concept in insurance and economics, because this gets to the marginal return, right? So think about the folks who are buying life insurance. Most likely, they have disposable income. If they have disposable income, most likely they're highly educated. If they're highly educated, they're thinking about risk and protecting themselves from a loss. So they tend to overinsure themselves. Plus, because they are more educated and have more money, they tend to live longer, which gets back to our first chapter, our first week. People, income and education can dictate how long someone can live. And so that's the correlation between people who can sometimes overinsure, but actually live longer. Negative risk coverage correlation. They buy life insurance. If you buy life insurance, you actually live longer because you're smarter, you have more income, and you have a better job. So it's interesting. Versus lower income folks, they are not willing to give money away for the protection of life insurance for a loss later on, because the money in their hand today is worth so much more money. So on a utility curve, they're actually still up. They're still going up the line on the utility curve because that money still means too much to them. The person who is starting to go down on the utility curve will say, I'll give up money to protect me from a loss that might not happen. If I'm going up on my utility curve, I am not willing to give my money for an unknown. So the lower income you are, the less likely you're going to buy life insurance. If you are low income, it could, generally speaking, mean there's an education barrier, which also could mean your social economic factors can impact your longevity of how long you're going to live. Okay, which is an interesting perspective. And then this was in the 90s. You don't see these so much more. Viatical settlements. These are when firms purchase a life insurance contract from a sick person, then collect the payout when he dies. There was actually, you saw this happen in Florida a lot around settlements. When someone was getting a settlement, a firm would buy the settlement, and then when the settlement occurs, they would get the payout. The adverse selection theory suggests this is related to HIV. Relatively healthy HIV patients sell their insurance contracts more readily. But this was not the case in the 1990s when HIV just started growing in the 80s and the 90s and people didn't know. You don't see this happen as much anymore. People essentially selling their life insurance contract anymore. But it's an interesting perspective around adverse selection, saying that someone who's healthy can beat the odds of their sickness. So they actually, you want to bet against them versus betting that they'll actually pass away. Okay. So how do we prevent this adverse selection? This is a big deal because think about Medicare for all. We are going to give everybody insurance. This is for your papers. And there will not be a copay and there will not be monthly premiums. Everything's through taxes. So that's a lot of people that will flood the market. Your sickest people will get as much care as they can. A lot of adverse selection, right? How do we prevent it? So what would adverse selection not occur? Why would adverse selection not occur? So what can we do to sort of prevent adverse selection? 4 main reasons. Customers misperceive their own risk. So if we could educate customers about their risk better so that they were more informed, then they would be able to purchase the right insurance policy. So this gets back to asymmetric information, right? Another reason, customers basically don't act on their private information. That would be, I know I have a surgery coming up in June. Empire Blue Cross Blue Shield doesn't know I have the surgery in June. I'm not going to tell them I have the surgery in June. And I'm going to buy a plan that's very rich, overinsured, because I know my surgery is coming up in June. That's acting on your private information. This would be you don't act on your private information. One way that you could get around that is, in theory, knowing that there's not different plans like high deductible plans versus copay plans. So people wouldn't have to feel the need to act on their private information. The other flip side is, as an insurer, as a health plan, I can accurately observe customer risks. So we used to be able to say, do you smoke? We used to be able to run blood tests, right? Like life insurance companies do. We used to be able to use more data points to basically predict someone's health insurance premium. We are no longer allowed to do that in the individual market. There's still some data you can use in the employer market when you're buying insurance, but insurers still don't have the tools to accurately observe customers' risk. One way to get away from adverse selection is allowing health plans to accurately observe customers' risk so they can price appropriately for it. The whole issue with adverse selection is health plans don't know how to price the plan for the population they have, and they find out how much the population costs after the fact, and it's too late. So by then, they're chasing the costs. They have to raise the price when people are leaving. When you raise the price when people leave, you don't get the revenue from the whole population, so you're chasing yourself. And then we talked about advantageous selection, people over purchasing what they need. And the only way that would happen is if prices are low. So if you have low prices, then people would over-insure themselves. And also, if they could perceive their own risk, they would over-insure themselves. So customers misperceive their own risk. In this study, they have a U.S. and Swedish novice drivers demand less insurance. 88% of U.S. students believe they are safer than the median driver. So this is interesting. You say, you ask people, do you drive well? Everyone's going to say, well, I drive really well. Other people don't drive well. And that's that misperception of how well you drive, because everyone thinks they're a good driver. But if you ask everybody else, everyone else thinks that everyone else is a bad driver. So someone's right, someone's wrong. This is interesting too. This goes back to misperceived risk. What are the chances that a man aged 85 to 89 will live to 100? Probability, US survey responded 31% chance that the man will live to 100. Actual mortality tables is predicted to be only 3%. So here, men are misperceiving their own risk. If they think they're going to live to 100 30% of the time, but it's only 3.4. What do you think is going to happen to that insurance policy? They're more likely to buy an insurance policy because they think they're going to live to 100. Where in real life, maybe they didn't need to because it's only 3.4, right? Live longer. Versus women, and this is a gender issue. What is the chances that a woman aged 70 to 74 will live to 85? The US survey predicts that 51% said they would. Mortality tables predict the answer is about 57%. So here, women are accurately perceiving their own risk, very close, 51 versus 57%. So they would be the best purchasers of insurance because they're predicting their mortality the best, if that makes sense. So they're not, adverse selection doesn't happen because they're actually perceiving their own risk properly, where men, for some strange reason, they don't know how to do it. And then customers do not act on their private information. So customers fail to realize their advantage. This happens when you lease a car. The example here is car owners can predict how many miles they will drive in the coming year with good accuracy. So for a lease, they know what lease to purchase so that they don't pay out too much more money. And so this is a way, if customers can not act on their private information, you tend to let go of adverse selection. Okay. And the one thing that they didn't bring up in the textbook, the absolute best way to get rid of adverse selection is random assignment, which doesn't work in the real world. But the beauty of RAND was they randomly assigned patients to these health plans, which means someone who needed insurance could have still ended up with a high deductible plan. Someone who didn't need insurance could have still ended up with a zero co-insurance plan. When you randomly assign, you're more likely not to have adverse selection than letting people pick the plan that they want to have, right? Insurers can accurately observe customers' risk. I think today what we do is after a year is full of data at an insurance plan, we can pretty much predict how that population will assist. Then the other thing we do is as new members come in, we use predictive modeling to say this member looks a lot like these members that we already have. Based on this data we have, we think this member is going to cost this much. So health plans are getting very smart with AI and artificial intelligence and machine learning. They're getting very smart to predict health expenditures. The other thing they're doing is bringing in data from other places. Credit score can be considered a good predictor of health. And if you think about it, if you pay your bills on time, potentially you're more likely to have medication adherence and take your medication on time, right? So there are correlations that we can have as predictors of health and predictors of risk that are outside of just health data. We talked about advantageous selection. Sometimes it is healthier, less risky people who are more likely to buy insurance. And we mentioned this. Higher income, better understanding of insurance benefits. And this really leads to the fact, which goes back to our first chapter, social economic impacts of how it impacts health. Smarter people that make more money tend to be efficient producers. And if you're efficient producers, you know how to navigate the system, which gets back to the cognitive ability. Okay, so this was a part of a chapter. I wanted to take the time to really dive into adverse selection because it's going to be a big deal for your paper on Medicare for All. Please make sure in your paper you think of ways to avoid adverse selection with your critique of how Medicare for All could impact the United States. Okay, thanks.